Good afternoon and welcome to yet another National Combined Grand Round on COVID-19 being held at the All Indian Institute of Medical Sciences, New Delhi in collaboration with Niti Aayog. We've been holding this Grand Round for now many weeks, and this week we're basically going to discuss cancer in the time of COVID-19. We are all aware that COVID-19 has had a huge impact as far as our day-to-day life is concerned and as far as clinical care is concerned. But there's been a lot of collateral damage which COVID-19 has caused as far as other illnesses are concerned. We've had a huge setback in the TB control program. For one, immunization program for the children has really suffered a lot because of the lockdown and because of various other aspects related to COVID-19. But one area which has really had a huge setback has been cancer itself. And cancer has had a huge setback because of a number of factors. One study, as a matter of fact, I remember from the UK, I think it was, which suggested that in CA breast there has been now a decrease in 5-year survival by almost 16%. And in colorectal cancer, that 5-year survival has come down by almost 11%. And that's not related to delay or related to treatment per se, but even in delay in the diagnosis. Patients are reluctant to come, the interventions or the diagnostic tests get delayed. All of this leads to patients coming at a more advanced stage, and therefore overall survival becomes less. Therefore, it's a huge challenge for us to look after patients who have cancer in this time of COVID, and that is why we decided that we must have one of our grand rounds on this, and the grand round for today is cancer in the time of COVID-19. I have with me an esteemed panelist. On my left is Dr. Lalit Kumar. He's Professor and Head of Medical Oncology at the All Indian Institute of Medical Sciences. I have on my right Professor D.N. Sharma, who's Professor and Head of Radiation Oncology at the All Indian Institute of Medical Sciences. I have Dr. Deo, who's Professor and Head Surgical Oncology. And next to him is Dr. Sushma Bhatnagar, who's Professor and Head Oncoanesthesia and Palliative Care at the All India Institute of Medical Sciences. And after her is Dr. Atul Sharma, who's a Professor of Medical Oncology. So we have a esteemed panel of surgical oncologists, of oncoanesthesia and palliative care specialists, and medical oncologists. And we have faculty and residents who will be presenting very interesting cases. We will first have the case presentation, after which topic discussion, and then we can have your questions as far as cancer in the time of COVID is concerned. If you have any questions, you can send it through WhatsApp on the number which is at the bottom. It's 9999692364, 9999692364. That's the number. And we'll start off with the case presentation. The first case, I'll ask Dr. Anuja Pandit, who is a faculty here, to talk to us on COVID-19 complicated by underlying cancer. So over to Dr. Anuja Pandit.
A very good afternoon to all. I'll be discussing a case of COVID-19 pneumonia complicated by underlying cancer. So we present a case of a 62-year-old female, a housewife and a non-smoker, who came to us with complaints of high-grade fever for the past 13 days, dry cough for the past 13 days, and shortness of breath for 10 days. She was a known case of systemic hypertension. She suffered from multiple myeloma for the past 7 years. She was receiving maintenance chemotherapy for the same, and she was currently admitted for hypercalcemia of malignancy in a private hospital. During her admission, she was diagnosed with COVID and then subsequently treated with plasma therapy 2 doses and remdesivir. 13 days after the symptom onset, she presented to NCI AIIMS. She was conscious and oriented, hemodynamically stable. She had a respiratory distress with a respiratory rate of 35 per minute and an oxygen saturation of 89% on room air and 92% on oxygen by a non-repeating mask. Her calcium levels were normal on presentation. On day 1, her X-ray showed bilateral lung infiltrates with multifocal consolidation and left-sided CP angle blunting. Her initial blood investigations revealed anemia and a normal leukocyte count. However, she was thrombocytopenic with platelet levels of 46,000 per deciliter, which gradually decreased over the next few days without any bleeding complications. Her serum creatinine, bilirubin, transaminases, and calcium levels were normal throughout. Since she was suffering from severe disease, we investigated her for inflammatory markers. and we found drastically increased levels of IL-6 and ferritin. She also had increased fibrinogen levels. However, her D-dimer levels and procalcitonin were normal. On day 4, she developed pneumomediastinum and right-sided supraclavicular subcutaneous emphysema, bilateral lung infiltrates more so in the lower zone, and left-sided CP angle blunting suggestive of mild left pleural effusion. She was then managed with high-flow nasal cannula requiring oxygen percentage of up to 90%. Awake proning was also done along with HFNC. As a part of the management protocol for severe disease, she was treated with steroids, anticoagulation, antibiotics, and supportive care. To start with, she was started with broad-spectrum antibiotic therapy, including ceftriaxone and doxycycline. She continued to have fever along with high FiO2 requirement. Bilateral lower limb swelling developed and DVT was ruled out. She was then intubated on day 5, requiring invasive ventilation, and she developed ARDS and pneumomediastinum. Antibiotic escalation was done to piperacillin tazobactam and levoflox. On day 7, her bilateral lung infiltrates had increased compared to the previous X-rays, suggestive of progressive infection. She also developed bilateral CP angle blunting. However, the pneumomediastinum had resolved on day 7. Her antibiotics were further upgraded to meropenem, clindamycin, levoflox, teicoplanin, dapsone, and primaquine to cover for cellulitis as well as for PCP. She developed septic shock requiring double vasopressor support. Her cultures were persistently sterile. On day 8, she suffered from a cardiac arrest and she passed away. So the additional issues we encountered in this patient was that she was immunocompromised due to her cancer status, which was she was suffering from multiple myeloma stage 3, more so because of the chemotherapy she was receiving. She developed severe COVID-19 pneumonia with ARDS, and she required steroids for management of the same. She had thrombocytopenia. She suffered from systemic hypertension, pneumomediastinum, and septic shock. So amongst the first 4,200 patients that we had seen at our center, 56 of them suffered from malignancies, out of which 38 patients had solid organ malignancies and 18 suffered from hematological malignancies with a median age of 47 years. 39 were males and 17 were females. 5 patients were smokers, 4 were diabetics, and 5 were hypertensive. Out of the 56 patients, 6 had severe disease, out of which 4 required high-flow nasal oxygen therapy, 2 required NIV. Out of those, 1 was subsequently intubated. Out of the 6 patients with severe disease, 5 patients died, taking the mortality of cancer patients with COVID to 8.9% at our center. In a meta-analysis including 22 studies studying the risk and prognosis of COVID-19 infection in cancer patients, they found a mortality of 21% and the rate of severe or critical disease of 45%, intensive care unit admissions at 14%, and mechanical ventilation rate of 11%. So on a double-arm analysis, they found that cancer patients had higher mortality, severe disease, ICU admissions, or mechanical ventilation rates compared to the non-cancer patients. Cancer patients had also significantly lower platelet levels and higher inflammatory markers such as D-dimer and C-reactive proteins, and a higher prothrombin time as well. So to conclude, cancer patients have a predisposing risk of infection due to immunosuppression by chemotherapy, immunotherapy, or molecular targeted therapy. They have an increased risk of developing complications during their hospital stay. And other cancer factors which can impact outcomes are the stage of the cancer or the phase of therapy, their comorbidities, the type of cancer therapy, or type of treatment received for COVID-19 infection, and the capacity of the healthcare system treating these patients. So COVID-19 infection can also impact the outcomes by delaying the diagnosis and therapy, which leads to tumor progression and ultimately poorer outcomes. So it is important that we balance the care for these patients. We need to balance the COVID-19 therapy with the cancer therapy as well. Therefore, diligent preventive care measures, full supportive care measures for immunosuppressed patients to minimize the risk of infection and limiting their patient visits to the hospital whenever it's possible, and using telecommunication technology becomes imperative during this pandemic to protect these vulnerable group of patients. Thank you.
Thank you very much, Dr. Pandit. And I think what she's shown is the challenges that one has in managing patients who are having COVID-19 and then who are having an underlying malignancy and develop COVID-19 infection. This patient also had thrombocytopenia, and you know that very often we give anticoagulants in these patients, and there's always a risk of excessive bleeding which may happen. Along with that, as she has shown, the mortality is significantly higher in patients who have an underlying malignancy and go on to unfortunately develop a secondary infection with COVID-19. So before we go to the next case, I'll just ask one quick question to Dr. Lalit Kumar. What measures would you suggest patients should do who are having an underlying cancer so that they can protect themselves from getting COVID-19? Because if they get COVID-19, it can be associated with a very poor prognosis.
Yes, sir. Actually, for patients who are on active treatment, then one can take precautions like giving the prophylactic antibiotics. And for the blood counts, like WBC count, we have GCSF, which could be given. And one can we can modulate the treatment in such a way so that it does not affect the outcome. Plus, we are able to, doses can be reduced based on the severity and the condition of the patient. So some of these measures can be helpful.
I think these are helpful. Along with that, all patients who have an underlying malignancy should get some education as far as infection control practices are concerned. It's very important for them to be careful in terms of exposure. So wearing a mask, maintaining physical distancing, hand washing becomes even more important for people who have an underlying malignancy, because for them, if they get COVID-19, it can lead to a much higher mortality. We'll move on to the next case, which is also trying to highlight again issues as far as cancers are concerned. And this is basically radiotherapy in a patient with COVID-19. And this will be presented by one of our faculty in radiation department of radiation oncology, Dr. Ramba Pandey. So Dr. Ramba Pandey, on to you for the next case.
Good afternoon. So I am going to present a case of carcinoma cervix who became positive during the radiotherapy treatment. So this was a 56-year-old postmenopausal multiparous woman with no comorbidities presented to our department on 8th August 2020 with complaints of discharge per vagina of 1 month duration, pain abdomen 1 month, burning micturition of 15 days duration. On clinical examination, she had a 4 into 4 centimeter growth involving cervix and both parametria, not extending to the lateral pelvic wall. This was a CT image of the patient, which shows growth involving the cervix and bilateral parametria short of pelvic wall. Biopsy suggestive of moderately differentiated squamous cell carcinoma. Rest of the investigations were within normal limit. So final diagnosis of carcinoma cervix, FIGO stage 2B, was established. This was the treatment plan. So she was planned for concurrent chemoradiation, external beam radiotherapy, 50.4 gray in 28 fraction over 5.5 weeks, followed by intracavitary brachytherapy, 7 gray in 3 fraction at weekly interval. This diagram depicts the entire treatment protocol of the patient, where external beam will last till 5.5 weeks, and this is followed by 3 sessions of ICRT at weekly interval on week 6, 7 and 8, and entire treatment gets completed within 56 days or 8 weeks. The patient completed the course of radiotherapy on 30th September 2020. Before external beam radiotherapy, we routinely don't do any COVID test, as external beam radiotherapy is delivered as an OPD procedure. However, after the completion of external beam radiotherapy, the patient was due for intracavitary brachytherapy, and it involves insertion of applicator in the uterus and vagina. Like any other surgical procedure, it is performed in OT under anesthesia or under some form of sedation. So COVID-19 test before ICRT is mandatory. So we did COVID-19 for our patient on 30th of September, which came to be positive. So brachytherapy was deferred and patient shifted to COVID facility. Currently, she is stable and asymptomatic. Repeat COVID test done on 13th of October, and the report is still awaited. So at this point of time, we had certain concern in our mind that treatment interruption due to COVID-19 infection can prolong the overall treatment time. This delay can impact the local control and survival in carcinoma cervix. Treatment prolongation more than 8 weeks compromises local control and survival by 1% per day. Performing brachytherapy in a COVID-infected patient is also a big challenge. So the possible option under current circumstances were omit brachy and switch over to further external beam radiotherapy, delay brachy till patient becomes COVID negative, perform brachy without any delay, delay brachy but not beyond 8 weeks even if she is found to be positive, and with modified brachy dose schedule. So the first three options were not viable, as omitting brachy and switching over to further external beam radiotherapy by IMRT or SBRT is not advisable as far as carcinoma cervix is concerned. Delay brachy till patient becomes COVID negative is also not an option because this may compromise the local control and the overall survival. Performing brachy without any delay was associated with increased risk to the healthcare worker and to the fellow patients. So delaying brachy but not beyond 8 weeks even if she was found to be positive was an option, and she was planned for 7 gray in 3 fraction in one day rather than weekly fractionation. So this was our current situation where patient was found to be positive. We have done COVID test again. 10 to 12 days have passed and COVID test has been repeated on 13th October and report is still awaited. So at this point of time, we have two options. If the patient comes negative, then we can safely go ahead and complete the ICRT with modified schedule where we will do ICRT in single application, 3 fraction will be delivered. However, even if the patient comes positive, we have to complete the treatment with the modified schedule and the overall treatment time will be 56 days or 8 weeks only. So this was a case report where Mark et al. Has performed brachytherapy for a COVID positive carcinoma cervix patient without any detrimental effect on the disease status. We also look for international guidelines at this point of time. So American Brachytherapy Society guideline recommend that brachytherapy should be done in a patient with carcinoma cervix who are COVID negative with some altered fractionation during this COVID-19 pandemic. However, if the patient is positive, then also if resources available, continue brachytherapy with proper PPE precautions. If resources not available, then brachytherapy can be delayed till 10 to 14 days post-infection and try to increase dose of brachytherapy by 5 gray cumulative dose for each week delay provided OAR constraints can be met. So the take-home message is intercurrent COVID-19 infection may interrupt the course of radiotherapy and might compromise the clinical outcome. RT should be resumed as soon as possible with modified dose schedule to complete the RT within prescribed time period, that is 8 weeks. Dilemma exists for asymptomatic COVID positive patients regarding brachytherapy procedure. Brachytherapy should not be replaced by external beam radiotherapy options like IMRT or SBRT. Brachytherapy can be performed in a asymptomatic COVID positive patient with proper precaution. Certain changes in radiotherapy practice may be the need of hour to decrease the risk of healthcare worker and other patients, which includes altered fractionation regimen of external beam radiotherapy, such as hypofractionation, altered fractionation regimen of brachytherapy, multiple fractions during single application, use of sedation or local anesthesia instead of general anesthesia. Thank you so much.
Thank you, Dr. Amma Pandey. I think you highlighted the challenges that you have once you're giving radiotherapy and a patient in between comes out to be positive. This patient was on brachytherapy also. So I have just two questions I just wanted to ask Dr. D.N. Sharma. One was, do you think there is, during COVID-19, an increase in the demand of radiotherapy as compared to other forms of treatment for cancers? and how much modification of protocol had to be done for this patient is being done routinely during this era of COVID-19 because patients are turning out to be COVID positive. It's something that we're having to do frequently, or it's something that is not that frequent.
Thank you, sir. There has been a surge of cases since there was a point when the surgeries were not being performed. And even the guidelines suggested surgery for these patients, but they were not taken up due to the reasons of the COVID. So there was a surge in the months of April, May, and part of June when we had cases even in early stages, and we had to accommodate them somehow by modifying certain protocols. The second part of the question is that how did we modify the protocols? The first thing that we resorted to the hyperfractionated schedules, which means shortening the treatment within the defined or the prescribed ethical limits, so that we can finish the treatment in a quicker time and we can accommodate more patients. The same was done for brachy also, that we can accommodate more patients where the brachy is mandatory, like in carcinoma cervix. So these were the modifications we have done as per the international guidelines regarding the modifications due to the surge in cases due to lack of surgery during that point of time.
Thank you very much. We will now move on to the next case, and I think one of the most important issues is how to do surgery in a patient who has an underlying malignancy and has, in the time of COVID. How frequently should you test this patient? What should you do after surgery in the post-operative period? And if the patient does become positive, then how do you manage this, and what are the risks as far as the surgeon or the healthcare workers are concerned? So we have Dr. Sandeep, who's a faculty in the Department of Surgical Oncology, who will be presenting cancer surgery in a patient with COVID-19. Over to Dr. Sandeep.
Good afternoon, everybody. Today I will be presenting a case of carcinoma esophagus in a pandemic situation. As we all know, delay in cancer treatment can affect prognosis as well as survival. COVID pandemic has affected cancer care services all over the world, and surgery and anesthesia are considered as high-risk interventions during COVID pandemic. Most of the cancer surgeries are considered either emergent, urgent, or semi-urgent. Cancer patients are more susceptible to COVID infection due to their immune changes in the body. Surgery in COVID-positive cancer patients carries a higher morbidity and mortality. There are various guidelines formulated for cancer surgery during COVID pandemic. They mainly focus on the status of COVID pandemic, whether the number of cases are static, either or rising or in decreasing trend. Availability of resources should be kept in mind. If resources are low, they should be diverted to COVID patient management. Training and patient prioritization are also important, where high biology and high stage disease of the cancer patient should be operated first as compared to low tumor biology and early stage disease. Strict surgical safety protocols like pre-op COVID testing and wearing of PPE should be done by the surgeons, and safety of healthcare workers and safety of cancer patients are of utmost importance. We come to the patient. He was a 64-year-old male. He presented to the GIC Cancer Care Clinic of our department with a history of progressive dysphagia. Clinical assessment was done by CT scan, upper GI endoscopy, and biopsy. Patient was diagnosed as a case of lower third of squamous cell carcinoma of esophagus. This is the CT pictures showing that locally advanced disease in the lower 1/3 of esophagus at the level of inferior pulmonary vein and below it. Patient was planned for NACT, and patient was given 2 cycles of 5-FU and cisplatin. After that, patient was converted to definitive chemoradiation in April 2020 due to COVID pandemic, disruption of surgical services at AIIMS, advanced age and comorbidities, and locally advanced status of the disease. Patient successfully completed chemoradiation in May 2020. 6 weeks post CTRT, the general condition of the patient was improved, dysphagia was relieved, response assessment was done by CT scan and upper GI endoscopy. There was a partial response and the disease was still there. COVID situation was improved by that time, and cancer surgical services were started at AIIMS in Delhi. So patient was offered curative surgical options. Pros and cons of the surgery was explained to the patient. This is the surgery we have planned. It is a transthoracic esophagectomy with 2-field lymph node dissection and gastric pull-up. This is a major complex surgery which involves right thoracotomy and mobilization of the esophagus, followed by midline laparotomy, mobilization of stomach and gastric tube formation, and finally cervical incision with mobilization of the remaining esophagus, resection of the esophagus, and gastric pull-up and anastomosis of the cervical stump and stomach tube. This is a complex and high-risk surgical intervention during COVID era because of high-risk prolonged exposure of aerosols. Anesthesia and critical care issues include fiber optic bronchoscopy, double lumen ET tube placement, prolonged surgery, and change of ET tube during the procedures, and ICU stay. All these procedures are aerosol generating, and they cause a exposure of the healthcare worker to the airway of the patient. Surgical issues include complex multi-field surgery, long duration of surgery of 4 to 5 years, for which surgeon has to wear a PPE, which can cause surgeon discomfort, poor visibility, movement restriction, and dehydration. This is the OT attire which a surgeon has to wear during the surgery of the COVID pandemic. In COVID pandemic, we have to wear a full PPE followed by a sterile gown with a respirator mask or goggles. N95 mask can also be used, and a sterile face shield, face shield or hood. Pre-op testing was done, and RT-PCR was of the patient was found to be negative. Patient was admitted, and rehabilitation of protocol were initiated. Transthoracic esophagectomy with two-field lymphadenectomy and gastric pull-up surgery was successfully performed on 10th September. Operative duration was 5 hours, and it was uneventful. Patient was shifted to ICU. Post-operative period, on day 2, patient was extubated. Feeding was started by FJ. On day 4, patient developed atrial fibrillation and dyspnea, which was managed in ICU. On day 8, bilious fluid came from the right ICD. Urgent CECT thorax was done, and features were suggestive of thoracic leak. So an emergency re-exploration was planned. On emergency re-exploration, which was done on 18th September, there were fibrous seditions and fluid collection in the pleural cavity. There is a patch of gastric conduit necrosis with leak in the mid portion of the conduit, which is quite unusual, because we can see that in this part, we can see the proximal and distal part of the conduits are almost normal, and there is a gangrenous patch in the mid part of the conduit. Retrospectively, we suspected it to be due to COVID-induced thrombosis, as COVID is known to cause thrombosis in the patients. So gastric conduit takedown was done. Patient was shifted to ICU. Post-operative patient was not maintaining the saturation because of despite of high FiO2. So we suspected a COVID, and X-ray suggested of infiltrates in the right side of the chest. In view of clinical suspicion, repeat COVID testing was done, and unfortunately it was positive. Patient was shifted to COVID ICU at NCI. Contact tracing and quarantine of high-risk surgical and ICU team members was done. Patient's relatives were also quarantined. Patient was managed successfully in a COVID management team. Repeat RT-PCR was done after 2 weeks, and it was found to be negative. Currently, patient is doing well and is planned for discharge. So in this patient, we want to show that the complexity in the management of the COVID positive cancer patient. This patient was with our facility for almost 5 months. He has undergone change in neoadjuvant plan. He undergone one elective and one emergency surgery, and finally he came out to be COVID positive after surgery, and he was shifted to COVID center, and he was managed successfully. So key points will be: managing cancer during COVID is a challenging part. Expertise and facilities to offer multimodality cancer management should be available. Surgical teams must be trained and ready to handle high elective risk and emergency surgeries. During prolonged treatment and hospital stay, repeat COVID testing is also important. Availability of expertise for COVID management are also critical. So these are the guidelines formulated by our department for managing the cancer surgery during COVID-19 pandemic. These are the performance of the department where we can say that during March, when the lockdown was being imposed, the number of surgeries are high, but as the lockdown was imposed, the number of surgery fell down to almost negligible, where we were able to manage only emergency cases. And during the month of April, we were busy in managing the resources, arranging PPE kits and space allocation for COVID, and gradually we have increased the number of surgery, and in September we are almost half of the surgery which we have done in the March. So we will thank the teams of medical fraternity, supporting staff and administration of AIIMS. Thank you.
Thank you very much, Dr. Sandeep, for an excellent case. And I have one or two questions which I'd like to ask both Dr. Deo and Dr. Sushma Bhatnagar. Dr. Deo, two questions that I had in my mind. One was, if there had not been a COVID pandemic, would this patient have been operated upfront in the beginning, or would you have continued with the same treatment protocol that you did at this point in time? And
Yeah.
yes, please go ahead.
This patient, actually, there's a slight modification in the preoperative protocol. He was a locally advanced lower third squamous cell esophageal cancer. As per our guidelines, routinely we use preoperative chemotherapy or chemoradiation in these patients. But here we started with preoperative chemotherapy, then converted into definitive chemoradiation. That is the modification because of the COVID pandemic we did in this case.
Okay. And Doctor, one question for Dr. Shukla Bhatnagar regarding cases like this, the challenges that the anesthetists face during managing such patients, because this is a long surgery and there is always a fear of aerosol generation while you're giving anesthesia. So, any special precautions that you would really like to highlight as far as from the anesthesia point of view?
Yes, sir. It is challenging, especially this kind of surgery where we need bronchoscopy, and when patient is re-explored that time, and then in his ICU stay, most of the time he was breathless, and chest physiotherapy, aerosol generating procedure like intubation, we re-intubated this patient. This is definitely a challenging, but however, with all the precautions, because we have now intubation protocols, we have made a chart in the operation theater so that every residents they follow the intubation protocol. We have made the protocol for bronchoscopy, emergency bronchoscopy, bronchoscopy intubation. So all these protocols are in place, and this patient, because we were expecting that he should have improved in first post-operative day after re-exploration, but he was not improving. That's why we suspected that we should do COVID testing, because there is a possibility that, and that is why he came out to be RT-PCR positive. We sent for RT-PCR and he came out to be positive. So that was the reason, because otherwise he was doing well and we thought that he should have been doing well. So that's the reason that X-ray was showing little this thing. Definitely it's challenging, but if we follow the protocols and if we take the precautions, I think everybody is confident in doing this.
Thank you very much. We'll move on to the last of the 4 cases that we have, and this is focusing on chemotherapy in a patient with COVID-19. This again is a big challenge because these patients have to keep coming regularly for the repeated cycles of chemotherapy, and one is always worried that in between, if they become COVID positive, how will it sort of affect the overall treatment strategy? And this is to highlight all of this. We have this very interesting case of chemotherapy in a patient with COVID-19, which will be presented by a faculty in the Department of Medical Oncology, Dr. Akash Kumar.
Let us discuss this case. This case is a 32-year-old military personnel by profession. There was no comorbidity. He was diagnosed as a case of Philadelphia positive B acute lymphoblastic leukemia at a private hospital on 24th April and started on induction chemotherapy with effect from 27th April. As you can see, he received 3 doses of vincristine donomycin as a part of induction chemotherapy, along with 1 intrathecal methotrexate and pegasparginius before coming to us. So on day 16 of induction chemotherapy, that was on 12th May 2020, he had complaints of low-grade fever, fatigue and myalgia and sore throat for 1 day. Due to the pandemic, there was a high risk of COVID-19 infection, so he underwent RT-PCR and that was positive. The patient was shifted to National Cancer Institute, AIIMS. At presentation to NCI on 14th May 2020, at admission there was no complaints of dyspnea, bleeding or any bleeding from any side or fever over last 24 hours. On examination, patient was febrile, pallor was present and rest of the examination was within normal limits. So the point of care testing showed SpO2 of 98% on room air, chest X-ray and ECG were normal. Hemogram had pancytopenia with a platelet of 23,000 and TLC of 320. We also did COVID-related markers, D-dimer, PT, APTT, CRP, ferritin, all were within normal limits. So he was categorized as mild infection. The plan was close vital monitoring and supportive care that consisted of oral paracetamol, vitamin C and zinc supplements. So we had 3 issues there, pancytopenia, active leukemia disease and active COVID-19 infection. So at that time in April 2020, we didn't have much of data coming from even from China or US as to what to do in such cases when cancer is complicated by COVID-19. Even we were not sure if steroid is useful, it's harmful. So still we went for a discussion in our department and we decided we should go ahead with individualized therapy in this case. We decided that we will continue with steroid and imatinib. We'll give vincristine that we gave on 18th May 2020. We withheld donomycin and L-asparaginase. Donomycin in view of a very high chances of febrile, very high chances of neutropenia, and asparaginase because it is associated with coagulopathy, that is another complication associated with COVID-2. So we avoided these two drugs. In supportive care, we continued with trimethoprim, sulfamethoxazole, acyclovir, and antifungal prophylaxis. Blood products we always supported during this stay. So during the hospital stay, all symptoms resolved by day 7. Patient did require platelets and PRBC support. He tolerated chemotherapy well. We continued we did a repeat COVID-19 testing that was repeated every weekly, and the results were persistently positive for next 6 weeks. Post 4 weeks of induction, we wanted to do a bone marrow assessment for CRs, morphological remission status, and we wanted to plan for next phase of chemotherapy. However, patient was very much reluctant at that time because of the fear of a persistently positive COVID-19 report. So we decided we will continue with only oral steroid and imatinib. As you can see, this is the trend of hemogram of that patient over this hospital stay. You can see TLC has shown a persistently rising trend, and so has been the platelets over these 6 weeks he was admitted there, and platelets were normalized. So repeat PCR testing for COVID-19 on 25th June 2020, he was that was negative. The patient was discharged on 25th June on tapering steroids and oral imatinib with a plan for assessment and further phases of chemotherapy. At discharge, hemoglobin was 7.8, TLC of 3000, and platelets of 158,000. So this is our take-home message. Chemotherapy is feasible in active COVID-19 infection. Appropriate selection of patients is very important. Complete interruption of cancer-directed therapy may be harmful, especially in active hematological malignancies where disease is very aggressive. Mild and symptomatic cases may be considered for therapy under very close monitoring. Thank you.
Thank you very much, Dr. Akash, for a very interesting case. And I have just one question that I'd like to ask Dr. Atul Sharma, who's a professor in medical oncology, that in patients who are asymptomatic and who are coming to IRCH regularly for chemotherapy, how frequently are we getting COVID tests done, or should we get it done at all, or should we not get it done considering the risk that is there?
Sir, as per the guidelines in our institute practice, for the patients who are asymptomatic, usually we don't do the COVID testing for the OPD. We do COVID testing as per the IDS guidelines for the patients who are being admitted for the bone marrow transplant and other high-dose chemotherapy protocols.
So as a routine, one is not recommending that for all patients who are coming for chemotherapy, if they're asymptomatic, we should really go ahead and do COVID testing unless they turn out.
They are symptomatic.
I think that's a very important message, because often people keep wondering, and there are patients who sometimes are asked to get repeated testing done, which to some extent becomes counterproductive and adds to the cost of the treatment per se.
Exactly.
So thank you very much. We will now move on to our topic presentation for today, and I'll just again once more remind all the audience that if they have any questions, they can send it through WhatsApp on the number at the bottom of the screen, that is 9999692364. And we now move on to the topic managing cancers during COVID-19, which will be covered by Dr. Sameer Bakshi, who is a professor in the Department of Medical Oncology at the All India Institute of Medical Sciences, New Delhi. So Dr. Sameer Bakshi.
Good afternoon, everybody. So I'll be talking about managing cancers during COVID-19. So when the pandemic started, cancer was considered as a high-risk background illness for developing COVID complications. And at that time, a lot of guidelines were made, but these guidelines were not obviously based on data, and they were actually based on the personal viewpoints of the experts. But with time, we have learned that it is the advanced age of the patient, the advanced stage of the cancer, male sex, poor performance status, and associated comorbidities in the patient, and hematological malignancies which actually predispose to the COVID complications. There is recent data that administration of chemotherapy in the last 4 weeks actually did not impact COVID outcomes. In the pre-COVID era, if we look at with treatment, there are more than 800,000 deaths occurring in India due to cancer every year. So if we don't treat cancer at all, we don't know how many deaths would be there. If we were to look at our cancer patients, they can be divided as below. Active cancer patients, those who have immediate risk of death if untreated. Those with early or locally advanced cancers which are potentially curable, those with advanced cancer or metastatic disease and are suitable for palliation only. And we have another group of cancer patients who have been treated and cured and they are off treatment at present. So let us see the questions that we all have in mind. Should cancer patients be offered standard cancer treatment as they were being offered in the pre-COVID time? Should there be alterations in the type of this standard therapy? And what should be the follow-up care of off-therapy patients? So guidelines for surgery were developed from the Department of Surgical Oncology headed by Dr. Deo, when to do surgery, when not to do surgery for various cancers. And the same has been followed in our department as per these guidelines. From the Department of Orthopedics, Dr. Shah Alam published the data on bone sarcoma surgeries. And we are proud to say that the team conducted as many surgeries as they would have done in the pre-COVID time. And not only that, 90% of these surgeries were major sarcoma surgeries. As far as radiation goes, those fractionation schedules are suitably modified so that the duration is shortened and there are less hospital visits for the patient. The brachytherapy services should continue except for the aerodigestive cancers. Now, those who are actively COVID positive, radiation may be delayed but not omitted. Specifically, if emergency radiation is needed for active bleeding, that should not be deferred. Now, what about chemotherapy? Now, the decision for chemotherapy depends on the intent of treatment. Are we dealing with a curative intent cancer like a blood cancer, or a palliative intent cancer where an example being a metastatic bone tumor? The other thing that we have to keep in mind is what will be the degree of benefit for a curative intent treatment. For example, in an adjuvant treatment after surgery, in a localized bone sarcoma, we know that the addition of treatment would make a huge difference and not that much of a difference if it was a localized soft tissue sarcoma. So if it's a curative intent treatment, we would like the treatment to continue, but we would like to make a lot of alterations if our intent was palliative. Coming to the alterations that we have made and developed guidelines, one is the increased use of growth factors. This would decrease the neutropenia and perhaps decrease hospital visits as well. We have also shortened the duration of therapy. For example, a treatment which we would otherwise give over 5 days, we have condensed it over 3 days so that the hospital visits and the potential exposure to COVID may be reduced. We have also looked at alternative treatments without affecting outcomes, such as looking for oral therapeutic agents in place of intravenous therapies. We have developed various guidelines from our center, some exclusively from our center and some in collaboration with various other centers across the country for various cancers. Coming to an important point, fever management in cancer. Now, COVID can cause fever, so can cancer, and so can the chemotherapy which we use can also cause cancer. So our protocol is we segregate the patients early, we rule out COVID, we keep a low threshold, but we must remember that even if this patient turns out to be COVID positive, do not forget to manage simultaneous febrile neutropenia complications, which could be due to the chemotherapy in addition to COVID. Coming to the palliative intent therapy. The word palliation means that we need to give comfort care. We need to make their life as comfortable as possible. And a lot of chemotherapy is used with palliative intent as well. But we must keep in mind when the logistics were curtailed, when the logistics were affected, the hospital visits were very difficult for patients, and we were not sure how much palliation we would get if intravenous therapy was used with a difficult hospital visit. We have also used a lot of oral metronomic chemotherapy in palliative intent patients, and this is in line with our previous publication from our center, where it has been an effective mode of treatment for solid tumors. Coming to another point, telemedicine and shared care. Generally, cancer care has been in major cities or tier 2 cities, but with COVID, we have made efforts to practice telemedicine specifically for off-therapy cancer patients and those who are getting oral therapy, and we have tried to build in a shared care model. And we think this is a healthy legacy of this pandemic. We have published this data as well, and we believe this will probably continue even once the pandemic subsides. The take-homes are: treat curative intent malignancies with minor modifications, as treatment for these diseases would add life years. And also, if we don't treat these cases, the curative intent would treat into palliative intent for these patients. The palliative intent patients need modified oral forms of therapy in view of the constrained logistics. There are also new research opportunities such as evaluating modifications in standard therapy to see if they are truly non-inferior, evaluating various oral modes of therapy which curtail hospital visits, and bringing telemedicine and shared care models of therapy into routine practice even after the pandemic subsides. I would like to acknowledge our hospital administration, which has managed the patients so effectively during this pandemic, and the entire staff of AIIMS and the Cancer Center. Thank you.
Thank you very much, Dr. Sameer Bakshi, for an excellent presentation. We have a number of questions, and I'll start with the first question, which I'll address both to Dr. Lalit Kumar and Dr. Deo. And this is a question which one of the doctors has asked, that how has COVID-19 affected a screening program as far as cancer is concerned, and what do you think will happen after the pandemic for cancer screening?
Yes, there has been some concerns that particularly the common cancers like oral cancer and breast cancer and cervix cancer, that the current government program which was being run for these three common cancers in the almost more than 150 districts in the country has been put on hold due to this COVID thing. So one can always argue that you probably will be delaying some of the cases. But I would say that like those patients who have some symptoms and they can go to the nearby physician and they are able to suspect, then they can undergo the proper investigations and should not delete that much.
I think that's a challenge because we have to do a lot of catching up, if I may put it that way. Dr. Deo.
Absolutely, sir. That's preparing for the future. I think we are still grappling with handling the current pandemic, but we need to prepare for the future also. We have now data available from Western countries where the standard national level screening programs have got disrupted for common cancers like breast, colorectal, and head and neck. We have data available, and most of these patients are likely to now they are in a better situation. They understood there was a fear of unknown at the beginning of the pandemic. Now the patients are started coming back to cancer centers. So the resuming surgeries and elective treatments is one challenge, and preparing for the increased cancer patient load. I think we need to start thinking strategize from, I think, now for the future increased cancer patient load.
Thank you. There's one question which is very specific by one of the persons in the audience, and I'll ask that to Dr. Atul. That he says, I have a COVID positive patient with metastasis, a primary unknown, and he has ascites. PET and CT scan has been done. Is it safe to tap the pleural, the ascitic fluid, and what could be the treatment strategy in such a situation?
So I think, sir, this is a specific question. So it appears that despite the PET CT scan and other studies, probably the primary is unknown. So if we need to do the tapping, that can be done without much fear. But the only thing is that the person who is doing it, whether ultrasound guided or so, they need to have the full, at least the level PP with taken precautions. That is number one. The sampling should be sent for the immunohistochemical marker or the cell block, and then they can do the INC so that they can find out what is the primary site. So that there are certain cancer which even with the advanced, like if this is an ovarian cancer with the ascites, then probably they respond very well to the chemotherapy, so that should be undertaken. Had it been after some immunohistochemical marker, some GI cancer, then the treatment directed to that can be done. If this is a gallbladder or pancreatic cancer, then we expect the prognosis is unlikely to be good, so we can send or refer for the best support to palliative care. So these are very important aspects.
Thank you very much. And I'd just like to say that we know that all secretions can also be infectious. So therefore, even if you do an ascitic tap, take all precautions because the virus may also be present in the ascitic fluid, and therefore you must also inform the lab accordingly. There is one interesting question which I have for Dr. D.N. Sharma. This is, what is the role of radiotherapy in lung pneumonia in COVID positive patients?
So thanks to the person who has asked this question for showing the interest in low dose radiation, because radiation is more feared than its effect for cancer treatment, I won't be able to share the details of the data which we have collected at center. We have done a trial, but this is mainly for countering the inflammation caused by the virus. If you see, the pneumonia is caused by the cytokines released by the viral infection. So in radiation, low doses causes the anti-inflammatory effect, which mitigates the pneumonitis, and therefore it reduces the severity of the pneumonia, and therefore preventing many deaths. So this is one area where a lot of research is going on. We have done a trial, but still going on, and we can't say the details of the data because it's not yet published. But the two trials which have been published so far, each having only 5 patients. So ours is the largest trial having more than that. And the response so far has been very encouraging, and of course the trial was very challenging, but the response has been very, very encouraging. Thank you.
Thank you very much. Dr. Sushma Bhatnagar, Dr. Samir Bakshi talked of palliative care as far as the oncology is concerned. But COVID-19 has thrown a lot of challenges as far as palliative care is concerned. And the question is, what are the challenges that you face as far as palliative care is concerned in this era of COVID-19? And there is now reluctance of patients, and especially cancer patients, to come to the hospital and take palliative care. So how do we address that problem?
Sir, again, this is true. This is challenging because many of the patients, they are not getting curative treatments. That's why they are becoming palliative, and the palliative care clinics are full because all these patients, they are requiring symptom management and pain management. So they are coming over there. to the palliative care clinic, and we are providing when patient is there. But it is also true that once you will give pain management or symptom management, whether indoor or OPD on the basis, once they go home, it is not that easy to come back. So telemedicine is really helping, and Department of Palliative Medicine is utilizing telemedicine facility a lot, and these patients are getting treated via telephone. Sometimes we do video conferencing, video talk, and we see the patient how he's behaving with the medication, and we advise. But definitely there is a problem that there are restrictions on advising medication. We cannot advise too many medications via telephone. But it is also true that once patient is on the medication, we can advise to continue. Only thing, sometimes those medications are not available. For example, opioids for pain management, then they have to come. Then we ask relatives to come and procure medication. So I think this way we are managing. But definitely OPDs of palliative medicines are overcrowded because of the advanced patients are going in advanced stage.
Thank you very much. This is another question which I'll ask Dr. Sameer Bakshi. This is basically, what is the experience with children who have malignancy and are COVID-19 positive? Do they progress in a similar manner as adults do, or do they behave differently? Do we have some idea on that?
So I think there is data that the patients who have had cancer and have developed COVID, their outcome has been no worse than the other non-cancer patients, at least in the pediatric age. And so there is data that the treatment should not be curtailed or changed in the pediatric age group for cancers.
So it should continue in the similar manner?
Yes, there is no.
Okay. So I think that's an important point that you've made. There's an interesting question which I'll address to Dr. Atul Sharma. The question is that, considering the fact that patients with cancer can progress rapidly, should we consider giving drugs like remdesivir to all cancer patients early, even with mild symptoms? It's a question which I don't think we have a definite answer. But I think
like you correctly said, sir, we don't have a definite answer, but probably only thing with regard to the cancer patient, like Akash highlighted earlier, we know that anybody who is on chemotherapy, we have to have a very low index of suspicion. Somebody presenting with the fever, which is a common symptom for the cancer because of the treatment, and other ILI or SARI-like symptoms. They are very much common in the patients who are neutropenic also. So these patients, we probably need to act early, and probably in one of the analysis, I believe that the remdesivir has been shown to decrease the mortality in the cancer patient also. But they are the established patient who have been given other COVID treatment along with the remdesivir and other agents.
So I don't think we have a definite answer whether cancer patients should be started treatment early, even if they have mild disease, in a more aggressive manner, and whether that will change the overall outcome. But currently, standard protocol would say that you would not treat them with aggressive treatment unless they have moderate to severe disease, and many patients, there is a question on that also, may have mild disease also. So I have one question for Dr. Lalit Kumar, which is basically asking that this is basically for you and for Dr. Deo, that in patients with active cancer and COVID-19, any extra treatment that you advise once they are discharged or sent home after having recovered from COVID-19?
Yes, actually, I'll just modify this to the type of the cancer. Actually, as it has been discussed, that whether it's a early cancer or very advanced cancer. So those like hematological cancers, if they are young patients and they are in remission, then generally you don't need really kind of any extra precautions, except like what we normally recommend for the COVID, that your mask and hand wash and all this distancing, and plus obviously the hygiene at home which they have to maintain. So, but the patients who are like advanced disease or so-called who are probably beyond the preview of the so-called curative treatment, so there one has to use the supportive medication. And there are a lot of things which have been kind of people keep on asking whether I can take this particular thing or with to immune booster or those kind of things. So the data is still kind of fluid kind of thing. We still don't have a very solid data for one or for the other. But I will take, if you take proper precautions, proper exercise, proper hygiene, and about your food, I think you should be okay.
So here I would like to respond to the dual challenge because in the follow-up post-treatment in cancer, we look for any relapses, treatment-related toxicity. But now we have the challenge of post-COVID long-term effects. So the physician has to be very careful. It's not only focus on the cancer, but we need to look at the long-term effects of COVID also, including pulmonary complications, thromboembolic events. So there are a lot of literature coming, long-term post-COVID effects. I think the cancer registry I'm looking after at IRCH, they've started a cancer registry program to look at the long-term outcomes along with cancer follow-ups and COVID follow-ups. Now it's a dual challenge. All the physicians and oncologists should be careful and keep a watch for long-term effects of COVID also.
I may just like to add here, like for example, we had just analyzed data on 16 myeloma patients, multiple myeloma, who were COVID positive, who became COVID positive. The first 3 patients, actually, they were in the beginning. They were terminal disease, particularly the multiply treated refractory. So those were the patients who could not make it. Next 13 patients, they could successfully be treated and discharged. So they really had no problem. 2 of these patients who have been discharged, they were having some pulmonary lesions on the chest X-ray, and they probably required oxygen therapy for a few weeks after the discharge at home.
Thank you very much. I think a continuation of this, which I'll ask Dr. Atul Sharma, is that cancer is a hypercoagulable state, and COVID is also associated with increased clotting. So do you think they should be more aggressive anticoagulants? And again, continuing with what was discussed, that should post-discharge these patients be put on thromboprophylaxis?
So I think, sir, we don't have the, like many times for the cancer patients who are on some form or other form of the treatment, we do give prophylaxis in the form of either the aspirin or low dose heparin for the, particularly with the myeloma, with those who are on immunomodulatory drugs and so on. Cancer definitely is considered as more prone for the thrombosis and this thing. But the problem with the cancer treatment is many of these patients, if they are treated aggressively, they have the associated thrombocytopenia, very critical thrombocytopenia. So if that is, they are falling into that platelet being less than 40-50,000, then we don't. But otherwise, we do resort to this thing. As long as they are ambulatory, we don't need to give these kind of the treatment. But if they are really bed bound or sick enough, then of course the prophylaxis antithrombotic treatment may be given.
Thank you. One question for Dr. Sameer Bakshi, which is basically, are there any specific cancers which are associated with a higher mortality with COVID-19? Is there any data as far as this is concerned?
So I think it has emerged that advanced age, advanced stage, male gender, these are the risk factors for increased mortality with COVID. There is an increased risk with hematological malignancies when they are not in remission, and there's more risk of COVID related deaths. But I would also like to state that hematological infections or malignancies, even otherwise, if they get infected, the risk of death is higher. So if there is pneumonia, even a non-COVID, the risk of death is higher. So I would say, other than hematological malignancies and advanced cancers, I would not place any other specific cancer as a risk for COVID-related complications.
You wanted to add something, Dr. Lalit?
Especially the patient with the relapse and refractory disease, they are more prone probably for the higher complications and mortality.
And also, sir, some data coming for the lung cancer patients, they are at increased risk of the mortality because of COVID.
Organ involvement, that causes more of a problem. So there's one interesting question which I'll ask Dr. Deo because it's related to the case that was presented. Was RT-PCR done on the biopsy sample of the patients with newly diagnosed carcinoma esophagus, and do you think it has any utility? Because you had shown that this patient had a post-COVID thrombotic leak.
Yes.
So do you think to confirm the diagnosis, we could have done an RT-PCR? Would that really have helped?
Tissue RT-PCR is currently not part of the routine recommendations. It is the blood test, that's what we do. It is only the clinical literature which is showing. Now we have case reports, few case reports where they have shown in the post-operative period the thromboembolic events. So that is just a presumption. We don't have a conclusive proof that this necrosis is because of COVID. So tissue RT-PCR is not part of routine recommendations as of now in the routine clinical practice.
Thank you. One question for Dr. Atul Kumar, which is Dr. Atul Sharma, which is basically a generic question that is it safe to do colonoscopy and a biopsy in a patient who is suspected to have CA rectum in COVID times?
So, sir, if we need a diagnosis, and this is probably taking all the precautions which we will be taking anyway for any other kind of invasive procedure, it is safe to do the colonoscopy or upper GI endoscopy. But the bottom line, you need to have the adequate precautions.
Can I just add a point, sir? Because again, there is some evidence that COVID, the fecal route spread is also known. So as Dr. Atul has highlighted, I think all the precautions should be taken, but colonoscopy and biopsy is routine, is part of a routine management protocols. They should not be deferred.
Thank you. So another question which is related to the first case that was presented, and I'll ask this to Dr. Shishma Bhatnagar, that this patient had pneumomediastinum. What do you think is the cause? Could it be related to ventilation, mechanical ventilation, or could it be related to the disease? And is it known to happen with both?
This can be related to both, basically. In COVID patients, we tend to give large, high PEEP, and which can cause pneumomediastinum. And because patient was already in hyper, means like he was in with all sorts of complication, hypercalcemic, and she came breathless. And maybe this was a disease related, but probably even a slightest of high PEEP can cause pneumomediastinum, and this is very, very common in COVID patients. And we have to be very cautious, and we have to be watchful on PEEP when we are treating cancer patients, especially with the ventilations.
Yes, I think it can occur because of both. We do know that even with non-invasive ventilation, when we give a high pressure as far as non-invasive ventilation is concerned, that itself can lead to pneumomediastinum and surgical emphysema and sometimes pneumothorax because of the peripheral involvement which happens as far as the COVID-19 infection in the lung is concerned. So the disease itself can also lead it. The positive pressure that we give either during non-invasive ventilation or during ventilation can also cause that. And the lung itself is damaged because of underlying acute lung injury. So it could have happened because of both of them. One question for Dr. Deo, which is now with the lockdown opening up and surgery, like you showed, is becoming more and more being done. What do you think would be the role of, how do you define elective versus non-elective surgery in cancer situation? And should we now start doing a lot of elective surgery which we had postponed, or were looking at other routes because of COVID-19? Because we know that COVID-19 infection along with surgery can lead to a higher mortality.
Yes, sir. So that's a good question. I think the situation in March, April, May was different. So at that time, we were looking for mitigating strategies, non-surgical options. But we have learned a lot during these last 6 months. Now we know the COVID is going to stay. We know how COVID is spreading. We also know how to take precautions and protect healthcare workers and patients. So the strategy should be to resume surgeries, all surgeries. So but that will depend on your resources, availability of resources. The focus should be on training your staff. That's very important, including the class 4, the nurses, the technicians should be trained. You need to prepare a strategy, then resume elective surgeries. That should be the motto. COVID is going to stay, we have learned. And if you look at the healthcare infection rates, globally and even in India, most of the surgical teams who are following good guidelines, the infection rates are not very high. If you take proper precautions, surgery can be done. Even complex surgeries can also be done successfully. Most of the physicians who got infected are primary physicians, general physicians at community level who are not taking proper precautions. So I think surgery should be resumed as early as possible, especially for cancer. I think that should be done as soon as possible.
I think so. I think we have learned a lot over the last 6 months, both in terms of COVID-19, how its pathophysiology, and the initial fear that we had for COVID-19 has now shown us that with proper precautions, we can actually go ahead and do a lot of non-COVID related work. The initial few months had a lot of fear, and people actually just, everything came to a halt, and many routine work was stopped because of this. Gradually, we have to now start doing that. Precautions have to be taken, we have to be careful, but whatever we've learned, we need to utilize that so that patient care becomes better.
So now we have the data available regarding the cancellations and delay of surgeries globally. This is a COVID Surge collaboration from Birmingham. Now, if you see the data they have published, the cancellations or delay of cancer surgery rates, they were to the tune of 20 to 30% in Europe and North America. But whereas in Asia and Africa, they're touching 70 to 80%. Because it's a huge numbers. So we need to do a lot of catch up, and the focus should be on resuming surgical services.
Thank you. So this is a question which I'm going to ask both Dr. Sameer Bakshi and Dr. Sushma Bhatnagar, and this is basically a question which says, how do we look at follow-up of cancer survivor patients via telemedicine, and especially if we want to look at palliative care also? So, Sameer, what is your opinion on cancer survivor follow-up? How frequently, how should you do it using telemedicine?
So in fact, we are currently doing telemedicine for the follow-up care of our patients, the follow-up, the off-therapy patients. So what we are basically doing is we need a certain number of tests that have to be done. It could be some blood tests, it could be a chest x-ray, it could be an ultrasound, it could be a CT scan. And depending on the type of cancer, we ask that family to get the test done in their local center, and then they send the test to us by either an email, and then we respond, we get the files out, we get the previous data out, we see how the test is, and we respond accordingly. And we also have a telephonic conversation with them if needed and if there's a specific doubt. So, and in addition, what we have done is a lot of the intermediary follow-ups, if they were to be seen after 3 months, we have asked them to follow with these tests at their local center, and if there is a problem, then they contact us. So that is what I meant with telemedicine and the shared care models. So that was number one. The same way for a lot of palliative care patients, what has been done is that a lot of the treatment which we would have otherwise used intravenously. A lot of palliative chemotherapy is actually practiced for advanced cancers. That is supposed to improve the quality of life and maybe marginally increase the duration of life as well. But what happens is then when we are increasing the duration of life by few months, but if the logistics are so difficult that the patient cannot reach or has to reach with a lot of problems, then that whole issue of bringing comfort to patient goes away. We also have to keep in mind that if we bring the patient to hospital, there are multiple visits of hospital to the hospital for these patients, and they don't get benefit. But if they come, they are predisposed to getting COVID, and they also predispose others to get COVID. So we have to keep that in mind, and because of that, we have made attempts to switch a lot of these intravenous therapies to oral forms of therapy. And a lot of counseling is being done on phone. So that is the change.
Dr. Sushma, you want to say anything about palliative care?
Yes, sir. So these patients, those who are well settled on medication with all symptom management and pain management, I think we are following them on telephonically on video consultation. But if a patient is not managing well at home with medication, we have developed a directory, telephone directory for whole of the country, so that if he can go to the nearby hospital in the same district or same state, then we try that he should go and we talk to the person that this person is under our follow-up and he is not managing well with the symptoms and pain management, and we try to send the nearest hospital. If it is not possible that the nearest hospital is not available, and sometimes the people are in the area where there is no hospital, then we try to manage with the video consultation. We call the patient's relatives, and if at all not possible, like patient with pleural effusion and it's a huge tense ascites and there is no one to handle, then we call the patient and we remove the fluid. We remove the fluid with from the lungs and ascitic, and patient get little symptom management, and then they go home. So this is the way we are managing. So telephonically, video consultation is really helping, and this telephone directory which we have made for whole of the country, I think it is really making a huge difference. So we can send patient that you can go to the nearby hospital where the patient, and we have a WhatsApp group for whole of the country, so for this.
Dr. Niti wanted to add.
Yeah, actually, sir, as Dr. Sameer said and Dr. Sma said, we till month of August, 31st August, we have done about 752 emails, which we communicated with the patients. And what we have done, like those patients who were supposed to come on those days in our, as per the appointment, when they did not turn up, so we called them back and then send them the email by message that this is our email. You can send your card or photocopy of the OPD card, and then we have sent the prescription to them, especially for the chronic myeloid leukemia. So because this is the oral therapy, and also for multiple myeloma when they have been on maintenance, so which really has helped to improve the follow-ups for these patients now, and especially like cancer ovary, like where we could give the oral metronomic therapy, especially for those recurrent disease, and that we have been able to do that. So this really was quite helpful.
You wanted to
Just wanted to add one line, sir, because regarding telemedicine, there's a big fillip this pandemic has given. So I urge all the audience to read the March 2020 publication by Medical Council of India. The telemedicine guidelines, they have mentioned everything, how to interact with patient, what are the platforms, what are the ethics, what is the consent, what you can prescribe. So everybody should read that before they start practicing telemedicine. It's very, very clear. It is a general framework for healthcare in India, but we have also prepared cancer-specific telemedicine guidelines for ICMR. We have submitted the document to ICMR. I think very soon they will approve it, and I think all the issues Dr. Sameer, Dr. Lalit, Dr. Sushma has highlighted, where all the situations it can be utilized has been highlighted in those guidelines.
Okay, final comment.
So one more important thing which we can do, if patient unfortunately is at the terminal stage, then definitely we counsel them. We ask them that they should not run away from here any other hospital, because we know the status of the, if it is a matter of few days or few hours, we ask them to stay back, and we try to manage their symptoms on telephone, sir. This is what we are, so this is what also we are providing through telephones.
So I think the way we're going to practice medicine is going to change dramatically in the post-COVID era, and telemedicine is going to play a huge role. And that is why the MCI came out with the guidelines way back in March. They're comprehensive, but they also provide some degree of advice as far as the medical legal issues are concerned. And it's important that all of us go through those guidelines as to the do's and don'ts of telemedicine. It's still work in progress. I think those guidelines have to be modified and made more changed with time. But telemedicine is something that is there to stay. It has its advantages. It does have disadvantages also. But we need to really work in the current era where telemedicine will play a major role. I have one more question, and after that, if we will see if we have time. Otherwise, I'll ask all the panelists to give their final take-home message. This question I'll ask Dr. Atul Sharma, which says that, is the incidence of asymptomatic COVID carrier more in cancer patients as compared to non-cancer patients? Any data on that?
So I don't think there enough data to say so. So asymptomatic COVID probably carrier in the cancer. If you see the registry data from the previous month, March, April, and so they say the prevalence and incidence of the COVID or cancer in the COVID or maybe up to depending upon what is the situation you are. Probably if you are talking about New York City or Italian, they found that 6 to 8% of patients will have COVID positivity. If you go some other places, they probably have 2 to 3% of the cancer patients having COVID positivity.
So I don't think this data, I'm not sure about this, but the only way one could really look at this is if you did antibody testing in all the cancer patients that we've had and see how many of them have antibodies to COVID-19 but never were tested or never were COVID positive. As we do as seroprevalence for the general population, maybe one can do a study and see seroprevalence among cancer patients and how many of them have antibodies. But currently, I don't think we can say that it is more in cancer as compared
So
to.
I'm not saying this. There are prevalence study from the two large hospitals.
That is looking at the
which say-
incidence.
Yeah, so 3 to 4% of the cancer patient will have positive.
Here, the argument is that how many of them will be asymptomatic and have COVID with underlying cancer. I don't think we have data.
We
to
don't
suggest
have that kind of.
But it's an interesting question. Samir, you wanted to add anything since you reviewed the literature? Any data on this?
No, sir. I don't have information on this asymptomatic COVID in cancer patients. I don't.
So it would be interesting to see whether we can gather data to see. I think the hypothesis here is that does COVID, the presence of a malignancy, lead to some sort of an immune system that you have COVID but you don't show present with it, and you are maybe more infectious because the virus can stay on in that individual for a longer period of time. We do know that. Or whether it's the other way around, that if you have an underlying immunocompromised state, you will definitely develop symptoms if you get COVID infection. Because we know that 40 to 60% of healthy people who develop COVID are usually asymptomatic. So does that also sort of translate to cancer patients?
We can maybe extrapolate the surgical data. I can just share our experience of cancer patients who are getting admitted and getting tested, who are not symptomatic. So out of the last 400 patients, odd patients we have operated, around 10 patients were tested positive who were asymptomatic. So that is the hospital-based data, which I think they're the best available as of today.
So we do see patients who are asymptomatic and turn out to be COVID positive. I'm just wondering what the number, because if you remember, one of the things that we said that asymptomatic patients coming for chemotherapy don't need to be tested. So it has a reflection on that.
So, sir, we don't do, but there are many centers outside the AIIMS probably which routinely practice this thing, sir.
No. So
We don't
as
suggest
we mentioned that there are patients who come for surgery and have underlying cancer but are asymptomatic. So it's possible that there are patients who come for chemotherapy
also.
and have COVID and are asymptomatic, and we don't test them.
We don't.
And we're not sure whether it has an effect on the outcome. So this is just thought, actually.
So one thought I would like to share that, like in many other infections, the antibody production may not be as robust as in a non-cancer patient.
Correct.
Because of the immunocompromised state. And that is the reason why the virus would stay longer. And that's why also the seroprevalence, we don't know if it will adequately pick up the patients, because the antibody development also may be delayed or may be subdued in the patients with cancer.
So that way the test may not be accurate enough to pick up what we're asking for, because we may not have a robust antibody
There is
response.
some data coming up which say that the sero clearance may be faster in cancer patient. Rather than the healthcare workers. Basically, there's a data from France which say that the 15 days it's probably faster clearance in the cancer patient problem.
So I think as we go along the pandemic and as we evolve, there is a lot of learning that we have, and that is in various diseases, including cancer. And we've had a very interesting discussion. So as we wrap up, I'll ask all the panelists to just give their final take-home message. And I'll start with Dr. Atul Sharma there. Any take-home message that you'd like to give to the audience?
The bottom line, the most important is that probably you can treat the cancer patient as they are to be treated in the pandemic also. You need to take adequate precautions. You also need to stress upon the patient and the family to have the hand hygiene and washing. So probably maintain the social distance, do not mix with the crowd, and take all the precautions so that they do not catch infection and they do not infect others.
Thank you, Dr. Sushma Bhatnagar.
So I will not repeat what Dr. Atul has said. Cancer, combination of cancer and COVID-19 is not good for patients, for caregivers, as well as for physician. But now we have come, although it's only 6 to 7 months, we have come long way. We have learned a lot that we can do. We can do a lot for cancer patients in every stage. In early stage, when they are curative, we can do something. When they are not curative, we can do something. And when they are in their terminal stage or in the palliative stage, we can do something. So we should be, after taking full precautions for healthcare providers. We should continue to give, and we should not deprive a single patient who is requiring curative treatment or palliative treatment. Sir. Thank you.
Yeah. So the picture is very clear now, sir. The mortality of COVID is 1 to 2% currently in India. The mortality of untreated cancer is 100%. So there is no need for a lot of discussion. The picture is very clear. We need to resume oncology services. Yes, there was a panic when the pandemic started, but we have learned our lessons and we have proven that it is feasible to do all standard cancer treatments with maybe minor modifications. The education of the patients, education of the treating physicians is very important, and the focus should be on resuming oncology services as early as possible. Thank you.
Dr. Lalit.
Yes, sir. I think I would say that people need not to be very apprehensive. That's the first thing. And those who are asymptomatic, even sometime COVID positive, as we were just discussing, you need not to really worry. Those who are on active treatment for cancer, I think they should continue with taking all due precautions, as Dr. Atul has emphasized. And those who are on the regular follow-ups, they can with some of the other methods, they can continue to remain on the follow-up and information can be provided. I would say that in addition to this, in general measures like take all the precautions for COVID about your food, regular exercise, and positive state of mind, which I think will be some simple
Most
things
important.
which will keep you fit and healthy.
Dr. D.N. Sharma, your take-home message.
So there's a need to modify the approach as far as radiation treatment is concerned, especially because this treatment is a prolonged treatment. Every patient requires a visit of like 5 to 7 weeks for the treatment. We have a risk stratification for approaching these patients. Group 1, where the radiation is used as a curative modality, where the radiation is likely to benefit in a concrete manner. So these patients, we should not defer or delay the treatment. The second group is where the radiation is used as an adjuvant setting after the surgery. The indications are dependent on the margin of benefit, and there we can take a decision for either to defer or delay or even abandon the treatment based on the margin of benefit. The third category is the patients who require palliation, and therefore radiation is very important palliative modality and must not delay, especially in patients like SVCO and bleeding CS cervix. So these patients, radiation must be delivered in time so as to give the benefit. The also a message for the radiation team workers, because it's a prolonged treatment and they are continuously exposed to the patients every day, and every day we treat like 150 patients on our machine. So therefore the radiation team is at a high risk. So therefore they must take all the precautions required for the treatment of these patients. Thank you, sir.
Thank you. Dr. Sameer Bakshi, your final comment.
So I think I have two comments to make. Number one, I think that telemedicine is a big take home from this pandemic that we have learned, and we have to make our patients learn, as well as we all have to get used to it. And I feel that this will stay even after the pandemic subsides. That's one take home. And my second take home is that a lot of research opportunities have opened up for us. A lot of these oral forms of therapy may be as good, non-inferior to our current intravenous forms of therapy, and they need to be systematically evaluated.
Thank you very much. I think we've had a very excellent discussion in this grand round on cancer in the times of COVID. We've learned that how important it is, and I think the important issue that has come out is that we need to move ahead. And when it comes to cancer, there is an urgent need to really come back to what was the pre-COVID era, whether it's screening, whether it's patients coming for testing if they have some suspicious red flags for having an underlying cancer. And it's our responsibility now to really start restoring services as far as cancers or other diseases or other illnesses are concerned for our patients. And as has been mentioned, we will have to live in a new normal, whether it be infection control, telemedicine, or trying to look at various strategies of being innovative in this time of COVID-19. So I'd like to take this opportunity to thank all the panelists, all the speakers, Dr. Anuja Pandit, Dr. Ramba Pandey, Dr. Sandeep and Dr. Akash for excellent presentation, Dr. Sameer Bakshi for really covering the topic, and all the panelists who spared their time for this grand round. Thank you very much and hope to see you next week for with another topic. Thank you.